I'm not sure, this abyss of nothingness, and we had no information whatsoever, no one to turn to. This was the hard part.
Mm-hmm.
So what I'd love to do is have a bit of a conversation with you about this gap that almost every stroke survivor that I talk to tells me that they experience in the very early days of going home, and then sometimes for many months.
This is the Recovery After Stroke podcast with Bill Gassiamis, helping you navigate recovery after stroke.
Hello and welcome to episode 215 of the Recovery After Stroke podcast. If you are a stroke survivor with a story to share about your experience with stroke and you've been thinking about reaching out to be a guest on the show, but were waiting for the right time to reach out, this is it. If you go to recoveryafterstroke.com, you'll find a form that you can fill out to apply to be a guest on the show. As soon as I receive it, I will respond with more details on how you can choose a time that works for you and me to meet over Zoom. Now, my guest today is Joseph Clark, a doctor in the field of neurophysiology who works with people to help get their brain and body as healthy as possible. Dr. Joseph Clark, welcome to the podcast.
Thanks, Bill. Nice to be here.
Lovely to have you here. I would love to know, I always get excited and shocked and humbled by the fact that there's a whole bunch of people on the planet who decide to become doctors of all sorts, especially medical doctors. And the purpose is to help people they haven't met yet, that they don't know, through things that we're going through, the most difficult times, for example, in our lives. And we've got this whole bunch of people inside of a hospital and outside of a hospital, researching, etc., that have got our back, or in my case, they had my brain. Can you give me a little bit of background about your journey to becoming a doctor and why you chose the field that you did?
Yeah, sure, of course. So a point of clarification, my doctorate is in neurophysiology. I'm not a medical doctor, but it's neurophysiology, neurophysiatry. I do have a medical license. I can, see and take care of people. And in America, that's called a physician extender. So I work with other physicians in a subspecialty that is most definitely neurophysiology, neurophysiatry, focusing on diagnosis, rehabilitation, management, treatment of traumatic brain injury and stroke. And in many places, those two are linked together. They have differences, no question. But when there are deficiencies that are in my purview, there's a lot of overlap with regard to the patients that I see who have had a stroke or a traumatic brain injury. And sometimes we have to be even more granular: hemorrhagic stroke, an ischemic stroke, traumatic brain injury with skull fracture, with hemorrhaging. There's, it can get pretty complicated. And how I got to this is really, for me, the brain was always a puzzle. One specific region of the brain can be very dedicated to a task, like a motor task or a vision task. And if we talk about, say, the frontal lobe or the frontal cortex or the prefrontal lobe, that particular area of the brain can be damaged. And sometimes it's damaged and a person has what's called a flat affect. They're just a lump. They don't want to do anything. And then sometimes they're hyperactive and disinhibited, and they're wild and all over the place. Almost the exact same injury can manifest in different ways. With a stroke, a person with a hemorrhagic stroke, it can sometimes seem fairly similar. Like if you have a 60 cc stroke in one person, well, a 60 cc stroke, hemorrhagic stroke in another person could be drastically different. And it could be because of metabolism, it could be because of location, it could be because of what we call a tight brain, a brain that fits tightly within your skull versus a person that does not have as tight a brain. And so the same...
Let me interrupt you for a sec. What's a 60 cc?
That would be 60 milliliters of blood. So that's the volume of bleeding. And
Uh-huh.
60 is very serious. But 60 is also on that line where some people do very well and some people never recover.
I always got curious after my brain hemorrhages when I met other people who were way more injured than me post stroke,
Mhm.
or had way more deficits. I always did kind of wonder why them? Why did they have that injury to that extent and I didn't have an injury? So the bleed amount is definitely one of those things. The location is definitely another one of those things. But you said something that's really interesting is depending on whether the brain fits in the skull,
Mhm.
if the skull is a different size or compared to the brain, that's
Mhm.
fascinating.
Right. So a pre-existing hydrocephalus or pre-existing brain atrophy, or just that's not how you developed,
Mm.
um, can give the brain a little bit more room should there be a hemorrhage, and then increased intracranial pressure from a bleed is a bad thing as well. And so there might be less intracranial pressure. So yes, all of those things come into play. And what we haven't even talked about, because there's lots to talk about,
Mm.
um, arterial versus venous. So arteries have a higher oxygen concentration. You probably heard of reactive oxygen species and oxygen-free radicals. Um, there's more in oxygenated blood, arterial blood, versus venous blood. So even the type of blood can come into play.
Wow. So if the blood vessel is leading to the heart to be reoxygenated as opposed to coming from the heart,
Mhm.
that we can have a different outcome. And are those outcomes worse when the blood is oxygenated or worse when the blood is not oxygenated?
Um, there's no absolute, but it tends to be worse when oxygenated. So the oxygen, oxygen is a wonderful molecule, but it can be very toxic when it's not controlled. And part of my research when in post hemorrhagic stroke patients identified bilirubin oxidation products, which we call boxes. And bilirubin oxidation products are produced in much higher concentration from arterial hemorrhagic stroke versus venous hemorrhaging. And it's because the oxygen oxidizes the bilirubin, and bilirubin is a component of blood. And then the bilirubin oxidation products, which again are called boxes, the boxes are actually three different boxes, box A, B, and C, and A and B are super toxic. C a little bit toxic, and that toxicity then produces a secondary biochemical damage from in the brain from the hemorrhage itself.
Okay. So not only do brain cells go offline because A, they're not receiving blood, B, they're being interrupted by the actual blood being outside of the blood vessel and then causing, well, poisoning, or how would you describe it?
I would call it a toxic metabolite. So it's a metabolite that is very toxic to brain and artery cells, and actually many cells. So yeah, poisoning maybe, but metabolic toxicity. Mhm.
Okay. And then that metabolic toxicity, is that as severe a problem uh, as not having oxygen going to that part of the brain, or are they similar? Or
Well, it's a tier. So tier one, the worst is no blood flow to the brain, and
mm,
that's very bad. Tier two is blood flow with a reasonable amount of oxygen. That's best. Blood flow with very little oxygen, that's bad, but not as bad as no blood flow, because blood flow with no oxygen still has good metabolites and takes away bad metabolites. The worst is if you have low or no blood flow plus toxic metabolites that aren't flushed. And that would be occurring if the boxes are building up. And that toxicity then makes more swelling. More swelling is more toxic. More swelling is more pressure. More pressure makes harder blood flow. And it can become and I know I'm talking to somebody who may have gone through a version of this.
mhm.
It can be a very bad series of events in the first 1 to 3 days after a hemorrhagic stroke.
So I had the first hemorrhage was what they call a microbleed, or a small bleed into the
Mhm.
brain. The
Mhm.
arteriovenous malformation burst, and it was leaking into the brain, and that
Mhm.
bleed was increasing in size over 7 days by the time I went to hospital. And it was about the size of, I think, your dime, something like that, like a dime, which is a 10-cent piece. And then that was causing the symptoms which I was experiencing, which was the numbness on my left side. So that was settled down after they gave me some medication, dexamethasone. It settled down, and all my sensation came back. And then 6 weeks later, there was another bleed, which was more dramatic, and the onset was a lot quicker. And that second bleed ended up being about the size, the amount of blood in the head was about the size of a golf ball.
Okay.
And that was sitting there for the best part of 2.5 years near the cerebellum. So what it did was that amount of blood clot then took away my memory, my ability to finish a sentence, to remember who came to visit me, to type an email, to concentrate, to focus. I didn't recognize my wife at one point. I couldn't drive then. I couldn't be my usual self before all of this happened. And it's as a result of this big clot being in my head and then just sitting there for quite a long time. And then the doctors told me that as time lapsed, the clot got smaller because it was being broken down or absorbed by the body or something like that. And as it got smaller, more and more of those things came back. All those things that I'd lost had come back, and they took about 1.5 to 2 years. And I was feeling my best that I had ever felt. And then I had the third bleed in November 2014, which was almost 2.5 years after the first bleed. And then I had brain surgery. So what you're describing that I experienced was that toxicity occurring. Is toxicity more damaging than that? Does it actually take brain cells offline forever, or does it interfere with them and then they come back like they did with me? What happens there? Do you know?
Well, the short answer is it depends. So the toxicity coming from the boxes, that is recoverable when it's the boxes are washed out, which is why I'm hesitant to say poison. It's more toxic. You get rid of it, and but when other things are going on, things start to add together. So the boxes are more like a toxin that you can flush. However, if there are other things going on like reactive oxygen species, oxygen-free radicals, now those things change cells and cell constituents at the molecular level. So, and it's called oxidation. And in chemistry, it's a covalent bond. So reactive oxygen species change the chemical structure of important chemicals, like basement membranes, like the membranes of the cell, like the vesicles, like the microtubules, and then they don't function as they should, and that becomes its own kind of poison, because now the fundamental operation of the cells has been altered, and the only way to fix it is literally carve it out, get rid of it, and replace it. That's not just good blood flow and let it flush. And both can occur. And the boxes are produced because of the reactive oxygen species. So both can be occurring at the same time. And then it becomes degrees.
Okay. Well, that's fascinating. So I've been down this journey now for the best part of 10 years. And it's really lovely to hear what you just said. For me, I'm the kind of guy I need to know exactly what's going on in my brain. And there was nobody that I could ask these questions who would answer in this specific way or in any way that made me understand what the blood in my head was doing other than causing me grief, I suppose. So now let's talk a little bit about neurophysiology and what it is. I know it's made up of two words, neuro and physiology, but what does that even mean?
Well, if you don't mind me saying, I'm kind of old, and the degree neurophysiology is not as prevalent as it used to be. it's been replaced by neuroscience. So it's the science of neuro. Neurophysiology is the physiology of the brain and the nerves. And physiology is how the cells and the tissues function, communicate, and talk to each other. So it has a little bit of chemistry, there's physiology, a little bit of anatomy, and then there's the extrinsic function, so what you see. So when I'm working, if you don't mind me segueing in this way as an
Absolutely.
example, if I'm working with a patient and I see that their, let's say, reaction times have slowed down. Now, my brain in physiology said, well, slower reaction times could be because of action potentials. Action potentials are part of physiology. So I may need to see how their action potentials are impacted. That might be slowing down the reaction test. Action potentials are analyzed in some cases by an EEG.
Okay,
so
so action potentials. Action
Okay.
potentials is the ability to do something. Is that part which instigates the action? Is that right?
Well, the action potential propagates the message.
Uh-huh.
Okay, so a cell, a neuron, or a glial cell, or even a sensory cell will initiate an action. So I prick my finger, I have a reaction. That's a reflex.
Uh-huh.
What sends the signal from here to here and back again are action potentials through axons and nerves. So action potentials are like wires and cables that are running the electricity to the different computers. So this is a computer, there's a little mini processor here, and they all talk to each other.
Okay. So the action potential of a cell or of a nerve is something that can be looked at. You can specifically work out whether that's functioning well or not functioning well.
Absolutely. Yep. Amplitude, speed, and frequency. Yes.
Okay. And the EEG is the echo. What is that?
Electroencephalogram.
That's
So electro for electricity.
Yeah.
Encephala is for the brain, and gram just means measurement.
Yeah. Okay. So we pop the amazing looking probes and all the different cables to the head. And then from there, we get feedback from the brain, and we're able to look at the charts and work out whether there is not enough energy, or too much, or what are we looking for?
All of that. Too much, too little, hyperactive, hypoactive, all of that. There are ranges that we should, all of our cells should be maintaining. And so too much and too little are both not great. And the analogy that I learned when I was learning this too many years ago is it's like walking on the precipice of a mountain, and you're walking along the path on the top of the mountain, and it's great. But too far to the right, you fall off and die. Too far to the left, you fall off and die. You want to stay right in the middle.
Okay, I understand. And then from there, you can potentially get some information about where that person may need support, what kind of interventions need to take place to support them.
Yes, absolutely.
Okay. Now, where in the whole team, where in the team that's supporting this person do you sit? Because then there's, I imagine, a whole bunch of other people that are around that person, that are looking at reports, that are meeting regularly to develop a path forward. Where does the neurophysiologist / neuroscientist sit in that whole team?
Right. So let me go through the steps, and that will help. So in the acute phase, when the initial, say, hemorrhagic stroke hits, some people, it can be like a bolt of lightning, and it hurts and things are really bad. That's done with the emergency physicians, neurosurgeons, emergency physicians, a neurologist in the acute phase to keep the body and the brain alive. Then there's the high acuity physicians, neurointensive care people, interventional neuroradiology, interventional neurosurgeons that would be either doing the surgery or managing the person after the surgery when the brain and body is in a very fragile state. And then there's two steps after that. There would be the in hospital where people are getting the person off of the acute monitoring so that the brain and body can, sustain without lots of monitoring because things are stable. And that would be like in hospital care. And then there's a rehabilitation facility. So now at 4 steps, right? Now, rehabilitation facilities are where people like me come into play to get a person like you after injury to higher functioning. And we start off simple, and that's activities of daily living. You can feed yourself, you can talk, you can walk. And simple is in air quotes because that's not necessarily simple. That can be very important. And then after some time, and that's where a decision occurs, there's the next phase of the getting you back to as close to your old you as possible. And that's where I deal with a lot of people. And I have dealt with people in the earlier phases, but I'm, somewhat specialized. And so I'm in that 5th phase where I work with a person or people to get you back to the old you. And I use that expression all the time. Before the date of your injury, before the date of your stroke, this is the old you. We want to get you back to the new you. And we talk about percentages. You're 50% of the old you. You're 60% of the old you. We work people back to the old you. That's where a lot of the neurophysiology people like myself come in, the physician extenders, to do those last pieces of helping a person get the brain and body as healthy as possible. And believe me, I'm saying brain and body for a reason, because if the brain isn't talking to the body, there's something missing. So we will have people on exercise bikes. We're doing all sorts of brain and body and eyes and balance and memory, all integrated to get a person back to their old you.
So it sounds like you work in the facility that I was in, similar. I may not have seen the person that did your role, for example, but then the people that I did see were the occupational therapists and the physical therapists. So it sounds like you work in conjunction or closely with that team. Is that right?
Absolutely. I work with OTs, PTs, and athletic trainers. ATs are doing a lot of rehab for coordination and physical rehabilitation. So OTs, ATs, PTs, speech therapists. Yes, I work with all of those.
Okay. I'm going to tell you a little story that you reminded me of. When you said we make sure that they can feed themselves, etc. One of my first things that I did in rehab was in occupational therapy when we were cooking for ourselves. But of course, I was in therapy for a month, learning how to walk again and use my left side again. And I was dumbfounded why that would make me cook my own meals or why that would make me prepare my own breakfast. Nobody explained to me that it was part of the rehabilitation process, or at least I didn't clue in. And I found myself making my own breakfast and being completely frustrated because I couldn't do it properly. And because I thought that they were supposed to help me get better, not I was supposed to cook my own food and wash up after myself. It was hilarious until I kind of complained about it. And then they said to me, well, this is part of your rehab. We need to make sure that when you go home, you can use your arm and your leg appropriately enough to cook yourself a meal. So that was really interesting time. The way I took that was negatively, but I understand now what it was for, and that's excellent. The other thing that happened was there was a lot of conversation before rehabilitation started. So I was at the facility, I would say, for about 2 days where I wasn't doing any rehab. I was just laying in bed waiting for rehab to start. And I kept being frustrated with the fact that why am I still in bed? Like, I'm here for rehabilitation. I should be doing the things that I see other people doing, on the particular devices. Why aren't I in there? And what I discovered after, again, complaining, because I like to whinge about things every once in a while when I'm feeling helpless, I suppose.
Sure. Oh, sure.
Yeah. I was told that what I'm being is evaluated to see what my abilities are, where my deficits are, where specifically the risks are, and what help I'm going to need. And once the evaluation was complete and everybody was in agreement, then they were going to set a course of action for me to go forward and do those next steps. So that was really interesting, again, to learn that although it seemed like I wasn't doing anything, the people in the background were working it all out, and they were finding the right approach that was going to be useful for me, and safe, I suppose, as well.
Yeah, safe is definitely in that factored in. Sure.
Yeah. So then that was a very interesting time. It felt like I was in a part of my life which was going to rehabilitate me to an extent and then set me home, get me out of this whole nearly, almost 3-year saga that had started with bleeds and all these deficits and all these issues and all these scares and fears and brain surgery. And it felt like I was going to a threshold that was going to take me over to this place where none of the bad stuff was anymore. It was all going to be plain sailing from then on. But then I went home, Joseph. And when I went home, I had no idea what I was doing. Not only did I have no idea what I was doing, there was no support there. And my wife, who before that, she was a mom, she was a wife, she was somebody who went to work and did her thing. She was a daughter to her parents. And she was all these things. What she wasn't was a nurse. What she wasn't was trained in the field of neuroscience in any way, shape, or form.
If you've had a stroke and you're in recovery, you'll know what a scary and confusing time it can be. You're likely to have a lot of questions going through your mind. Like, how long will it take to recover? Will I actually recover? What things should I avoid in case I make matters worse? Doctors will explain things, but obviously you've never had a stroke before. You probably don't know what questions to ask. If this is you, you may be missing out on doing things that could help speed up your recovery. If you're finding yourself in that situation, stop worrying and head to recoveryafterstroke.com, where you can download a guide that will help you. It's called 7 Questions to Ask Your Doctor About Your Stroke. These 7 questions are the ones Bill wished he'd asked when he was recovering from a stroke. They'll not only help you better understand your condition, they'll help you take a more active role in your recovery. Head to the website now, recoveryafterstroke.com, and download the guide. It's free.
And we were trying to navigate, I'm not sure, this abyss of nothingness, and we had no information whatsoever, no one to turn to. This was the hard part. So what I'd love to do is have a bit of a conversation with you about this gap that almost every stroke survivor that I talk to tells me that they experience in the very early days of going home, and then sometimes for many months. How do you guys deal with that, knowing that you are going to send people home to this kind of space of no information and no support or lack of support?
Right. Well, I really have to say we do it very poorly. Okay. And it's disheartening for you. It's disheartening for me, for us, because if you notice, when I was talking about getting people back to the old you, I'm talking 60%, 70%, 85%. I don't work with people to their 100%. That's not the way I work. The system works in America and Australia. I've also worked in France and England, and I can tell you it's the same in all of them. There's this dead zone, and that may not be a great term, but a lot of people post-stroke will get to a percentage at, let's say, 75% of the old you, using my terminology. And then they go home. And, mom isn't a nurse, wife isn't a nurse, husband isn't a nurse, doesn't have experience in this. you're left to either try and resurrect some of the stuff that you did when you were in hospital with the therapist and do some of that again, or try yourself. I mean, trial and error. And I'm going to tell you what I tell people, and it's inadequate. And I when I'm saying it, I know it's inadequate, but we all need to work better on getting the system more facile for the patient. And I'm going to say right now, and hopefully in just a second, support groups are helpful because a lot of people have been through it before. Sometimes the support groups are very helpful, sometimes they're less helpful, but there are several that I do refer people to. But let me paraphrase my expression when I have somebody that I'm discharging from care. And I'll say something like, we've agreed that you're at 75%. We are, discharging you from care. You're going to go home. You can do things like the activities of daily living. There's more room for improvement. We've taught you a lot of methods that you can help keep up the progress. But the progress is going to be slow for now, and you really need to keep working at it. And people are getting depressed. So then I say, you may get to a point 6 months from now and think things aren't great, but then you might see me or somebody you haven't seen for a while, and they're like, hey, you're a lot better than you were 3 months ago or 4 months ago. Because hopefully it's going to continue getting better, and maybe you'll get to 100%, maybe not, but you're not done if you keep working. And there are some support groups. But unfortunately, the medical system is not going to be there for you unless something bad happens. Please don't have anything bad happen. But we want you to keep getting better and keep moving forward. And that is kind of the goal right now. And then there's that's the main part of the conversation. There is another part of the conversation that I want to say, because it's very important in this sort of discharge conversation. And that is, if you get to something that we haven't trained you on and you suddenly have forgotten it, okay? And I give examples. You're okay to drive. All right, let's say you're okay to drive. And for the first time since the injury, you're going to drive to grandma's and you don't remember how to get to grandma's. That could occur. That part of your brain could have been damaged. Don't worry about it. Don't stress. That's impetus to come back, and we're going to work some of the memory things that are some of the older memories, right? Because I can't know everything that could occur. I literally had somebody that we did a lot of rehab with, and we had them on a stationary bicycle, a ton. The first time they got on a regular bicycle, they couldn't bicycle. Can't do everything. And it was a female, and the female came back and said, I can't bicycle. Okay, so we had to work balance and, some other things, because we can't do everything. But if there's something relatively important, okay, then we'll work on that a little bit as well. And that's where things can continue to progress. But it really is an imperfect system for what we in the business call the last mile. If you think of it as a journey, that last mile, sadly, the patients are on their own.
Yeah. And sounds like that last mile is going to be the one that's more intensely resource heavy. Like, it's going to need a lot of resources to get to that end of that last mile. And I remember telling people when they were asking me, how's your recovery coming along? I would say to them, I'm 95%. And I was saying that for years, trying to work out how I'm going to get to 96%, and my 95% 3 or 4 years later was way different compared to my 95% at the beginning when I first started saying that. My original 95% wasn't, in fact, anywhere near 95%, I don't believe.
Right, sure.
It's something that I imagined was, but then I couldn't judge because I had no way to judge. I only judged myself because I was upright. I was, for example, able to walk to the kitchen, make something to eat, and get back to the couch. And in hindsight, I wasn't anywhere near 95%, but in my mind, I thought that I was. The other thing was I didn't get the opportunity to ring the facility and go, hey, I'm struggling with this thing. Remember when you helped me out with all this stuff, I've hit a wall. What are your tips? Or can I attend again? Or there seems to have been no, and not for the lack of wanting, I would imagine, but no suggestion to touch base if necessary with anyone from the rehabilitation facility. Perhaps with your doctors, but again, your doctors are then taking the same role that they were before the bleeds, which was, oh yeah, come in for a meeting, come for a checkup, go get some bloods, do this, do that. You know, there was no additional support. Go and see, for example, it didn't say to me, go and see a neuropsychologist to determine your cognitive ability and to know what to train. So I know that America and Australia are similar in the way that people have explained to me the gaps in the support. And I know there's a lot of people listening right now who are going, yeah, I am that person. What am I supposed to do with something? What could we tell people who are listening about what they can do to take a little bit of action to support themselves or to get more support? At least in America, that the feedback you give me might be more relevant in America, but it'll still be relevant here or around the world where people are listening from, and it might jog them and their memory to do something that they didn't think that they should do or that they could do. What's something else that people can do now who are listening?
Well, with all due respect, you're one of the answers, Bill, right? People need to listen to people like you who have been through it. Find other helpful tips that are helping them, because everyone is different. There is no one answer. Support groups where there's a group of people that have been through something similar, and what have they been able to do? My biggest patient referral is literally patients from support groups where my patients have gone to the support group and somebody says, well, I'm having this problem. Oh, well, Dr. Clark can help you with that. So, and I'm not advertising, I'm just giving an example, not practicing medicine, none of that stuff. But the network and the communicating, because I can't give one answer. It could be speech therapy, it could be memory, it could be psychology, it could be nutrition. I had a person post-stroke who had a balance problem, but he didn't have a balance problem, but it came across as a balance problem. And I don't want to go into all the details, but talking, communicating, networking, finding like-minded people, and then finding a clinician who's in the field. And it doesn't have to be a medical doctor. In America, there are physician extenders, nurse practitioners, athletic trainers, physical therapists, occupational therapists, speech therapists, psychologists, who usually work with physicians and can make referrals or suggestions on the right person or people to see for specific things.
Yeah.
Addressing specific things.
Yeah, definitely don't do it on your own, is what I'm getting out of this. Is you need to get involved with groups, whether they are on social media or locally to you, whatever you prefer, and then you need to be able to communicate with each person and get a feel for maybe they know somebody that can help you, or maybe they've dealt with something similar to you and they've got some advice or some tips. It's definitely not something to try and work out alone. It's unlikely that you're going to work out this part of stroke recovery on your own. We don't have the tools, the resources, the energy, the capacity in the brain. All sorts of things are difficult after a stroke. The physical limitations, for example. So I love that idea of kind of getting more involved in a community, or as much involved in a community as you have the energy to do so. Because there's a lot of people that have been there through this before you. You're not on your own. You might feel like it, but you're definitely not on your own.
Right. Everybody is different, but there are a lot of similarities that can, from historical precedent. Other people have been through it, and they may have ideas on how you might help with your next step.
Yeah, you briefly mentioned nutrition. I think nutrition is one of the keys to supporting the brain. And it's a journey that I think most stroke survivors should go on. They should learn about how better to support their brain after stroke so that it serves them better and their deficits are not as serious. Their brain fog is not as crazy. Now, we met because you and your colleagues contacted me a little while ago to tell me about a product that you're developing, hopefully to support people with their brain and to help the brain create better, more efficient energy and use that more effectively. Now, this is not an ad, and I wanted to talk about it because it's really important, because it is one of those things to supplement, like many other supplements that already exist out there, which are in similar or different forms, that is designed to create a place where the brain can operate more efficiently. Now, your product is called Tricerebro. I know it's in the very early stages of development and being made available to the public, but tell me a little bit about the journey that got you from all the stuff that you're doing to finding this other way to also help people get their brain working.
Sure. And thanks for the question, Bill. So the journey is fascinating. I will abbreviate it a little bit. So I was working with a neurosurgeon in England, and he and I, and several of us, but we communicated a lot. We came to the conclusion that after stroke, and this was actually mostly hemorrhagic stroke patients, neurosurgeons take care of a lot of those. After hemorrhagic stroke, the patients tended to be, the patient's brains tended to be in an energy depleted situation. Now, energy metabolism is critical for almost all brain functions. And we were doing magnetic resonance spectroscopy and found that a lot of the brains were metabolically compromised. And then we brainstormed on, well, what are things that are good for brain energy metabolism? And believe me, we went through lots of them. You start this big and we came down to this. And the three we came down to was creatine, beta-hydroxybutyrate, and magnesium. And they're all essential for brain energy metabolism, and actually the whole body energy metabolism, but the brain to a unique situation. And we came to the conclusion for those three were very good for the brain.
Let's go back for a sec. Let's go back for a sec. So what are those three? Now, I reckon that most people that have gone to the gym have heard of creatine. I'm not sure how many have heard of beta-hydroxybutyrate. And what was the next one?
Magnesium.
And magnesium. And most people would have heard of magnesium. In the old days, I used to take magnesium for muscle relaxation, for things like that, to support that type of thing. So tell me about what they are and how they support or how they help in the brain.
Right. So, yeah, thanks. Sorry about that. I got ahead of myself. So creatine is a natural compound. The human body can make it, but the human body can only make about 2 grams a day. Creatine is essential inside the brain for energy metabolism because creatine gets converted to creatine phosphate, and creatine phosphate is a buffer that maintains the concentration of ATP high. ATP is the energy currency. Without ATP, we can't have action potentials we talked about earlier. We really cannot have any metabolic function because all metabolic function is paid for through ATP. Phosphocreatine buffers ATP concentration, in other words, keeps it high. So it's like a gas reserve. Creatine plus creatine phosphate is a gasoline reserve for ATP, with ATP being gasoline.
Okay, so we can differentiate between the people who take it for the gym and the people who take it for their brain. What's the difference? Why do you know why might the people taking it for the gym take it, and then what's the benefit? What's the difference for the people that are taking it for their brain? Now, in the brain, it's creating energy, but what are the gym junkies doing it for?
So creatine, it has similar benefits for both. And that is creatine has benefits to all tissues that have what's called a high and dynamic energy demand. So muscles, my biceps doing nothing. Then I curl 50 pounds, my biceps has a high energy demand. It went from low to high. So that's a high and dynamic energy demand. Now, when my brain is talking, and literally if I'm speaking, there are 5 main regions of the brain that have to talk to each other rapidly with high energy to be able to get, mouth music. Speech is something that is impaired in a lot of stroke patients. Now, sometimes it's from damage, but sometimes it's from energy mismatch. And again, there's lots of reasons. But the creatine is helping the brain, like the muscle, in that the brain regions have high and dynamic energy demands. And so therefore, it's maintaining the ability to meet those high and dynamic energy demands. Instead of a contraction, it's a lot of firing of the action potentials.
Okay, so it's a similar type of contraction that's not physically visible, that's happening in the brain, for lack of a better way to describe it. And as a result, the larger levels of creatine or the greater quantities of creatine available, the more potential for the brain to take up that creatine and then use it so that it can create these action potentials.
And create and maintain those action potentials. Yes, absolutely.
Right. Okay, awesome. So what about magnesium? What does it do again in the brain? Because I know what I used it for, you hear people who suffer from cramps in the calves or wherever. Somebody might say to them, take some magnesium, it helps. What does it do in the brain?
So in the brain, it does a lot of things. The 2 main things that I'll talk about are magnesium is an essential, and I mean essential cofactor for ATP, which I just mentioned. So in other words, if you don't have enough magnesium, you might as well not have as much ATP. So for every single ATP, one ATP molecule, each ATP molecule is literally holding a magnesium. And if it's not holding magnesium, it can't work. So ATP is an essential cofactor for the use of the function of ATP. Magnesium also is a beneficial antagonist of calcium. Calcium is a very important molecule, but after a brain injury, after a stroke, calcium control is often lost or the control is diminished. So calcium is now having detrimental effects because calcium can overload the brain, and it can say with extra calcium in and around the brain cells, it can release more vesicles, more neurotransmitters. So you lose control of your neurotransmitters. These cells don't talk to each other well. Magnesium will temper that, won't stop it, but it'll temper that detrimental effect of the calcium toxicity because too much calcium is most definitely toxic. So magnesium definitely has 2 benefits for the brain under those circumstances.
I know you're not a nutritionist, so we're going to put a disclaimer here because I'm going to ask you a question about nutrition. Don't listen to us, folks. Don't do what we say.
Right.
This is just a conversation. Always consult your medical team for information on your specific condition. So if calcium can be a problem, then would you say that my conclusion that you should avoid dairy and high calcium food in that time, would that be something worth considering and worth doing or not?
Not automatically. Again, that would be consult a dietitian, a nutritionist, because I don't know what their blood levels are. Right. So if their blood levels are already normal, then the answer is yes. If the blood levels are low, maybe the low calcium actually contributed to the stroke. That can absolutely occur. A person can also be on calcium channel blockers for blood pressure. And obviously we know that misaligned blood pressure, not a precise term, can cause or contribute to ischemic and hemorrhagic strokes. So I'm going to have to answer not automatically, but certainly feel free to consult a physician, and hopefully that physician's going to say, first thing I want to do is get a blood test.
I love that. I love that. I never would have expected that that's what would have come out of it. So calcium can be responsible or partly responsible or contribute to stroke.
Absolutely, yes. So many blood pressure medications are calcium channel blockers that lower the amount of calcium that gets into the cells. And so if a person is on a calcium channel blocker for a while and then they go off of it, their blood pressure can go up. And we absolutely know a drastic, unexpected rise in blood pressure can cause a hemorrhagic stroke. So the answer is yes. It's not a one-step process.
Yeah.
But yeah, I can connect those dots.
Fascinating. Wow. Okay. So what about beta hydroxybutyrate? What is that? I've never heard of it before. And tell me what does it do?
So beta hydroxybutyrate is a fascinating molecule. It is one of the ketone bodies. Some people talk about a ketogenic diet. There are two physiological ketone bodies, acetoacetate and beta hydroxybutyrate. The two physiological ketone bodies circulate in the bloodstream on about a ratio, not written in stone, but about a ratio of 4:1, 4 beta hydroxybutyrate, 1 acetoacetate. So beta hydroxybutyrate is the more prevalent one. Beta hydroxybutyrate is the brain's second favorite food. Favorite food number one is glucose, but glucose has problems with regard to diabetes, hemoglobin A1C, glycosylation. Beta hydroxybutyrate doesn't have that problem. And glucose, when it gets into the brain, it costs energy. And the energy metabolism of the brain is already compromised. So to use glucose, the brain has to actually expend energy. Beta hydroxybutyrate, when it gets into the brain, the first thing it does, gives off energy. There is no energy investment to get the energy out. The energy of beta hydroxybutyrate, the structure of beta hydroxybutyrate is such that it doesn't need energy to give the energy out. It liberates the energy pretty much right away. And so and then after that, beta hydroxybutyrate then feeds into the mitochondrial system. The mitochondria is what makes a huge majority of the ATP in the brain. There are other ways to make ATP, but believe me, the mitochondria is well and above all of the others. And beta hydroxybutyrate and acetoacetate both feed into the mitochondria to help make a lot more ATP. Okay.
So as a general rule, a person can support their brain by supplementing with, say, creatine, magnesium, and beta hydroxybutyrate. Now, that's what the product you're developing does. It's combining those three things to support the brain. If people have got better levels of those, what are they? Minerals, chemicals? What are they?
Well, magnesium is a mineral. It's a metal. And then the other two are chemicals, creatine and beta hydroxybutyrate.
If they've got those, more of those available, is that supporting brain function? What is it doing? What might people notice that they're doing that's happening easier or better or recovering from? Like, what might they experience?
The goal in the way the product was designed is better energy metabolism and energy signaling. How that is manifest to the person, back to the physiology, the functional physiology, is different person to person, but the most common things are more fluent speech, because the speech requires a lot of energy, less brain fog. There's a lot of, in my vernacular, temporal disturbance with people. They feel slow. Things are happening around them, sometimes too fast, sometimes too slow, or they're perceived slow, or they were walking and all of a sudden there was a car and it seemed like it was going 100 miles an hour, but it wasn't. Those are temporal disturbances. And all of those metabolites help improve timing, because the timing within the brain requires the energy to be there all the time. If the energy is mismatched, then the timing is lost, and then there are these temporal disturbances. A little bit with memory, as far as the short-term memory, not the long-term memory. So remembering shopping lists, what you were just saying in a conversation. Things that are involved in energy metabolism, temporal disturbances, brain fog, brain fatigue. That's where the Tricerapro can help.
So we've spoken about something that can support the brain after the stroke, after going home. There's this gap. I suffered from chronic fatigue so bad that getting up from the couch to go to the bathroom was a chore, and then it had me wiped out for hours later. And the fatigue changed and got less impactful over the years as it went on. But I'm 10 years down, and I still, from time to time, get impacted with fatigue. What I've noticed is that some foods, when I eat certain foods, they interrupt my energy levels. And although I'm eating food and supposedly that's supposed to help, that actually makes my brain not work so well. So what are some of do you know of the types of things that might interfere with the uptake of magnesium or creatine, or the production of natural occurring creatine, beta hydroxybutyrate, and magnesium? What are some of the things we might consider avoiding or paying attention to if we consume it, and how that might make us feel, so that we are not getting in our own way when it comes to energy and fatigue and the way that the brain is operating?
The first thing that comes to mind that screams at me is fructose, high fructose corn syrup, the processed sugar that's in a lot of processed foods. You know, the Twinkies, the grocery store, donuts, that type of thing.
Sodas.
Those things, yes. Those are very negatively impactful on the liver metabolism, which is important for the metabolites that go to the brain. The brain actually does not like fructose, but if the liver is occupying its time managing the metabolism of the fructose, the high fructose corn syrup, it can't manage the other things for the brain.
Uh-huh.
And that one just screams at me.
So that's interesting, because I've never heard sugar and the liver being spoken about together. I've heard about sugar and the fact that we need to create more insulin so that the insulin can deal with that, and then that's really energy taxing on the body. And then and then if you're not exercising, you have way too much energy that's coming in, and you're not able to do anything with it, expend it in any way, because you've had a stroke and you might not be as physical yet, or you might not have the energy to do it. But how does the liver get involved in dealing with or metabolizing glucose? Because I assumed that it was just the insulin, the pancreas, doing all the hard lifting.
Right. Well, we were talking about diet. So, and that preface is important, because the way I think about it is, if we eat something, goes into our stomachs and goes into our intestines, 70% of the stuff, the nutrients that go through the gut goes through the liver first. All right. And so the liver is filtering, processing, testing. So it's got to manage all of the fats, the good fats, the bad fats. It's got to manage the glucose, the sucrose, the dextrose, the maltose, and the fructose, the high fructose corn syrup. And I mean, let's do the high fructose corn syrup, because I've been bashing on it, and I'm going to continue. So high fructose corn syrup, when it gets into the liver, and you can consume grams of the stuff in one cola. And when it gets into the liver actually has to take 2 phosphates and 2 ATPs, and it's spending energy to phosphorylate it, so chemically modifying it. And it can take up so much of the phosphate from the rest of the body that phosphate could have been on magnesium or calcium. So now the fructose is impacting the magnesium and calcium concentration in the body. Also, that fructose now needs more water, so it's absorbing the water from the rest of the body. So now you have a hydration maybe a little bit of an imbalance, but it's changing the metabolic environment. Now the liver needs to do something with it. Maybe it's going to convert it to fat. So now the fructose goes to fat. So you're now making more unhealthy fats. Or maybe the fructose is going through and being produced to acetoacetate beta hydroxybutyrate. That could be a good thing, but that's costly. Now, in small amounts, that cost is very beneficial because the liver now expends the cost, and then that investment in cost, energy cost, the brain benefits from. But if you're taking something like the beta hydroxybutyrate or other supplements, the liver can make other decisions on what to do with that high fructose corn syrup. So, or, after it's been processed. So the liver has a tremendous job when you drink that 12 ounces of cola.
Okay. And I picked up the things that pricked my ears were ATP. So we spoke about ATP at the beginning of the conversation, and we spoke about it now. At the beginning, we talked about how important it was for the brain, and it's necessary, and how necessary it is to have an abundance of it to support the brain. And what you're saying is when we consume something like a soda, the ATP, instead of being used at the brain, is being used in the liver to deal with the high fructose corn syrup and metabolize that, and therefore depleting our ATP levels, and therefore leaving less for the brain to use.
Not directly, but yes. There's a couple of steps in there, but yes.
Yeah. Okay. All right.
It's a negative impact on the overall energy metabolism. The answer is yes, absolutely.
Okay. Well, that's the first time I've heard that. That's great, because that adds a couple of more bits of information in my knowledge. I know that we should avoid high fructose corn syrup, but the question is, I didn't really understand specifically why, other than the general reasons, which is it's not good for you. And that was good enough for me. And also I noticed how I felt after I drank a soda after the brain injury, and I felt terrible a little while later, like 20, 30 minutes later. So that's very interesting. Well, you can see what kind of guy I am. I'm extremely curious. I want answers to questions, then answers to that and that, and we could go on like this forever. I really appreciate your time coming in and giving us a little bit of information on what to do after we go home and we're lacking that one-on-one support, and we need to do something to support ourselves and to start somewhere. I would encourage people to really get curious about nutrition and how that supports the brain, and to consider what they can add to their diet, but more importantly, what they can take out of their diet. Because I know that I was in my way a lot at the beginning. I was getting in the way of my own recovery by just doing things that I didn't know weren't supporting me until I became curious about it. I also didn't have somebody like you, Joe, that I could ring up and have a conversation with and say, hey, should I be doing this or should I be doing that? Just from a general conversation perspective, I didn't have that. Nobody does. We don't have access to people like you regularly unless you happen to be our family member. So I really appreciate the fact that you came on and you shared some of this information with the listeners. I think it's going to help a lot.
Yeah, super happy to be here, Bill. Thanks for having me.
My pleasure. Thanks for being on the podcast. Thanks for joining us on today's episode. To learn more about my guests, including links, and to download a full transcript of the entire interview, please go to recoveryafterstroke.com/episodes. If you would like to support this podcast, the best way to do it is to leave a 5-star review and a few words about what the show means to you on iTunes and Spotify. If you are watching on YouTube, comment below the video, like this episode, and subscribe. Hit the notification bell to get notified of new episodes as they become available. Now, sharing this show with family and friends on social media will make it possible for people who may need this type of content to find it easier, and that may make a massive difference to their recovery. Now, thanks again for being here, and I really appreciate you listening, and see you on the next episode.
Importantly, we present many podcasts designed to give you an insight and understanding into the experiences of other individuals. Opinions and treatment protocols discussed during any podcast are the individual's own experience, and we do not necessarily share the same opinion, nor do we recommend any treatment protocol discussed. All content on this website and any linked blog, podcast, or video material controlled this website or content is created and produced for informational purposes only and is largely based on the personal experience of Bill Gassiamis. The content is intended to complement your medical treatment and support healing. It is not intended to be a substitute for professional medical advice and should not be relied on as health advice. The information is general and may not be suitable for your personal injuries, circumstances, or health objectives. Do not use our content as a standalone resource to diagnose, treat, cure, or prevent any disease for therapeutic purposes or as a substitute for the advice of a health professional. Never delay seeking advice or disregard the advice of a medical professional, your doctor, or your rehabilitation program based on our content. If you have any questions or concerns about your health or medical condition, please seek guidance from a doctor or other medical professional. If you are experiencing a health emergency or think you might be, call 000 if in Australia, or your local emergency number immediately for emergency assistance, or go to the nearest hospital emergency department. Medical information changes constantly. While we aim to provide current, quality information in our content, we do not provide any guarantees and assume no legal liability or responsibility for the accuracy, currency, or completeness of the content. If you choose to rely on any information within our content, you do so solely at your own risk. We are careful with links we provide. However, third-party links from our website are followed at your own risk, and we are not responsible for any information you find there.